Hi everyone. Hi Andrea. Thank you for your message, and you, Peter. Right then, we'll get going. It is 6 o'clock Friday, so I won't hold you for too long. We had a really good session last Friday, so hopefully, hey Namir, good to see you again, mate. So hopefully this session will be just as good. We had some really good chat in the chat box last week, so that was really good. Week 5, end of week 5, going into week 6 next week. So we'll do another OSCE next Monday, but we got to finish this one off first. So all of you that have watched these, you should know who I am by now. My name is Mike, and run movement therapy education and movement therapy clinics. So I just wanted to let you know about this because it's I think I mentioned it on Wednesday. It was only just sorted out this week, but Dan, Lawrence, and I, we both obviously Dan's the education director for Rock Tape, and I'm one of their instructors. So we were thinking of ways that we can do a course online. So we're going to do a taping course online, and so if you've never done it before or you want a refresher, then feel free to join us. It's we're going to run it over 2 weeks. We're going to create a private Facebook group for whoever's on it to join, and we'll do the assessments via the Facebook group. So you'll have a task to do after we've demonstrated some things. You'll then have to do a video of you doing the techniques, and then post them on our private group. So it should be good fun, that one. And if all goes well, then we could probably think of other ways to do courses online as well. So I've been running my diploma whilst we're in lockdown as normal, apart from obviously the hands-on parts of it. So all of the theory stuff we've been able to deliver and do it quite interactively. So hopefully this will work well as well. So we are on day 3 of the case history. So we've looked at case history, picked out some key points, did that on Wednesday, and then we've started to create a sieve and sift through that information and create some justifications for a clinical impression. So we're going to have a look at some of those today. There were some really good thoughts that were emailed to me or messaged to me on the Facebook group. So thank you for those. You definitely getting used to the way of doing these now, which is really good. So the plan for this session is, what the hell do we do? So we've got this person that's come in with all these issues, and so what's the next step? And well, I kind of want to theorize from there as well. Well, if they didn't have that nasty stuff, what else could we do if we could treat them as well? Yeah, so have a look at a usual kind of clinical case that you would get in, because obviously these are quite unusual. They're in the kind of 1% of ones that you would see in your career. So that's what we're planning today. So just move me out the way. So these are the key points from the sieve that I put together on Wednesday. So just to go over these again to refresh your memory. So we've got a 65-year-old woman who's been a teacher for 35 years in primary schools. So one of the reasons why that was put in there is because of the predisposing factors that has on the biomechanics of your body. So if you think about the size of the chairs, the size of the tables and the desk, obviously it depends on what kind of age range she taught with. I mean, she's not very tall herself, so it wouldn't be a massive impact, but you're going to be on your haunches and leaning over for most of your career for 35 years. So if someone's got a grumbly back and has had that for a while and doesn't really exercise, then it's, you know, that there may be reason in her job that is predisposing her to that problem. She's 13 stone and 5'3", so she was obese, and so that's obviously going to bring other comorbidities with it, and immediately making you think about some of the things that she could have wrong with her health in general. She's a heavy smoker, enjoys fatty foods. She's very tired. and has been for the last year. She's recently been on a long holiday in Australia, and that kind of sparked off a lot of you thinking about DVTs, which is great. But then obviously DVTs are usually in the calf, but that they don't have to be in the calf, and that's what we're going to have a talk about today. She's got a constant deep ache in the left groin inguinal area, and this was from 2 weeks ago, and it was a rapid onset, so pretty quick to happen. And the lower lumbar spine located on the left and left gluteal area, she's also had for 2 weeks, so she's getting these radiating symptoms into the left side as well. And she complains of her left thigh, upper leg as feeling dead, and it's worse on exertion. Okay, so one of the reasons why that's in there is to get you to think, and I mentioned this on Wednesday, is it a nerve problem? So is there a problem with the sensory feedback going back into the spinal cord for that region? So is it nerve root, or is it somewhere on the pathway of the nerves going down to the leg? Or is it a blood supply problem? Okay, so and again, we'll have a chat about those things in a sec. This lumbar spine pain, which we talked about, been a feature for 10 years, worse in the morning. Usually, like osteoarthritic symptoms are worse first thing, and then as they get moving, they feel a bit better. So that's quite typical of a arthritic presentation. So it's worth having that on your list as some kind of changes in the lumbar spine. But she is 65, so it's the kind of things that you would expect if there were changes. Okay, and the changes don't necessarily have to be painful. So there may be other reasons why this person is feeling symptoms. She's finding it difficult to get comfortable on the sofa or chair. So again, one of the reasons that was in there is because of the position that she's in. So when you're in that position, you're in a deep hip flexed position, and you will compress some regions around the hip. Yeah, and one of the regions around the hip that you would compress is around the femoral triangle, and that femoral triangle, if I just if you've not heard of it before, let me just get you this up. Just show you this. So it is a region around the inguinal area, however you want to say it, and within that region you've got your femoral artery, your femoral vein, your femoral nerve, and the lymphatic vessels that supply the leg. Okay, so if you're in a hip flex position and you're quite overweight as well, then that region may be compressed when you're sitting, which may have exacerbated the symptoms. Let's just go back to the slides a sec. Okay, so we've also got a bit of a curveball thrown in. So father died of cancer, and it was probably liver cancer from the description, because she said that he had yellow skin, so had jaundice. So it's pointing towards liver cancer. So maybe she has it as well, potentially. She eats a lot of fatty foods, and she's obese, and she's got it in the family as well. So there are a few markers there that are possibly pointing towards cancer. Yeah, she's got intermittent pain in the right upper quadrant of her abdomen, which is where your liver is. Okay, so again, potentially that could be an issue. Problems with not problems, but quite a lot of cream in a coffee. So again, not great nutrition, especially if someone is obese and also eats fatty food. So we've got quite a few things there that could create problems with their digestive system. Oh yeah, one of the things we mentioned on Wednesday was the fact that the bile that's produced from the liver and the gallbladder is that's what emulsifies fats. So if she's having, and we don't know when her symptoms were because she didn't say, but if they're having problems after eating fatty foods, then it may be an indication that there's a problem with emulsifying fats, and that may give her some digestive discomfort. So it's possibly one of the things that could be wrong. Breathlessness on exertion. That's linking in to all of the problems with her cardiovascular system. So if she has got a problem with blood supply, then and her cardiovascular health in general, when she exerts herself, she's going to be breathless. She's going to find it difficult to get going. And then we've got loses control of her bladder when she laughs or coughs. Could possibly, I mean, it's one of those things where if she exercised and kept healthy, then may not be a problem. But it could just be a problem because of having children. But with a lack of physiotherapy afterwards, or it could be a metastatic spread from the liver. Okay, so because cancer in that region may cause bladder changes. Okay, so again, look, there's all these little kind of clues in there to point you in these directions. So these were the things that we came up with last time, and I've added some from some of the suggestions that you guys have put in as well. So cancer, but why? Because of the father, probable liver cancer that he had. She's got upper right quadrant pain and possible metastatic spread to the bladder, and she's got night pain as well. Okay, so that would be a GP referral. Possible problem with her lungs, so COPD, a chronic obstructive pulmonary disorder or disease, breathlessness on exertion, and she's a smoker. So that's a GP referral as well. Spondylosis, she's got lumbar spine pain. Basically, spondylosis is general aging of the spine, and she's 65, so you would expect that. Potentially some kind of cervical cancer. Yeah, that's really good, Peter. Maybe cancer of the womb. Given the pain into that hip region as well, that's another potential, especially with her history, her family history. Yeah, definitely, that's good. And then we've got cardiovascular disease, arterial occlusion. So possibly an occlusion to the iliac artery. And I'll show you this in a bit more detail. Breathlessness. Symptoms in the thigh. She's a smoker, she's obese, she's been on a long journey, and there was a sudden onset. Okay, so all kind of indicating things like a DVT would be, but obviously not in the calf, which is where we usually think a DVT would be. And then we've got femoral nerve compression. Again, you're going to compress the femoral nerve in that position as well. Because of the dead feeling in the thigh, we don't exactly know where. I think it might have said the whole leg, I can't remember. But depending on where it was, if it was just the front of the thigh, then it may be some kind of femoral nerve issue as well. Okay, so we can do a nerve tension test, and I'll show you that in a second. Okay, one of the things that was in there was talking about ibuprofen use, and she didn't have an excessive use. I think it was 500 milligram a day, and she'd been taking that since she got back from Australia, which was only 2 weeks. So I mean, it's a little bit longer than you would like. You'd expect symptoms to have eased in that time. She takes quite for arthro. Yeah, exactly. Yeah, good. Yeah, some kind of atherosclerotic changes, so changes in the lumen of the arteries. Yeah, really good, Peter. Good. Yeah, so this paper here I've got for you, I managed to get hold of it, so I'm just sharing that with you there. Yeah, I thought you meant that, Peter. Yeah. So I've just shared the paper about ibuprofen use in musculoskeletal care. Okay, so this is from 2003. But it's got some really good information in there, some advice about using ibuprofen. These are a couple of things from it. So to treat musculoskeletal injuries effectively, the clinician must have realistic expectations about the capabilities of non-steroidal anti-inflammatory drugs. That's what NSAIDs is, okay, and convey them to the patient. NSAIDs are rarely a substitute for rehabilitation and activity modification. Okay, so I've got a different role to some. So if you work as a clinician, then you can give advice about these kind of things. Obviously, I wouldn't go against the advice of their doctor, but you can give the patient information so that they can make an informed decision about what they're doing. But it's gastrointestinal bleeding is secondary to NSAID use is the 15th leading cause of death in the United States. Okay, so but overuse of non-steroidal anti-inflammatories is one of the 15th biggest causes of death in the US. So again, this may be linked to the case because of the gastrointestinal symptoms and the fact she's taking it. But to be fair, she hadn't been taking it for that long and not much. Okay, so there are some real issues with taking those kind of drugs. I know it's quite staggering, to be honest. So if we have a look at this is from the NHS website about liver cancer and the kind of symptoms that you would get. And looking at it, it's unlikely that she has it. It's possible, but it's moving down the list of likelihoods. We've got unintentional weight loss as one of the signs or symptoms, and she hasn't got that. Loss of appetite, it doesn't seem as if she's got that. Feeling very full after eating, didn't mention that. Feeling of being sick, didn't really mention that. Pain or swelling in your abdomen, yes, there was pain, so that's one thing. Feeling very tired and weak was another, and her family history. So there weren't many things that ticked the liver cancer box. It was a possible, but it was probably down the list. Okay, so that was that one. It was more likely to be this. So we've got an iliac artery occlusion. So an occlusion is basically a blockage. So you've got the lumen of the artery, and then when there's a build-up of plaque on the inside, as Peter was saying, you get changes in the blood flow to that region. Okay, so I'll just pop some thing on here. So this bit here, so that blood vessel there, that's the descending aorta. So you've got the aorta that comes out of the heart and then immediately comes down, runs alongside your spine on that left hand side, and then it splits around the level of L3, so around the belly button level, into two arteries coming down here and here, and those are called your iliac arteries. Then you've got, if I just draw this in a dotted line if I can, then you've got your inguinal or inguinal ligament across there, and then when it goes underneath that ligament area, it then turns into the femoral artery. Okay, so it's the same artery, it's just given different names depending on where it travels to. Okay, so so what that will do, if you've got a blockage there, it's going to make your leg numb because you are not getting any blood supply. So if you're trying to exert yourself, which was one of the issues that she had, your muscles need oxygen. And if your muscles can't get the oxygen, then they start to fatigue and they'll start to hurt. Okay, so it feeds into her symptoms quite nicely. And the fact she'd been on a long flight, and the fact she was a smoker, and the fact she was obese. It kind of all those things kind of tick the box. So I managed to find this paper. This was a British chap that flew to Nigeria. He was 55, and he went into hospital after landing, like pretty much straight away, complaining of pain in his leg. And if you have a look on the picture, just turn that down a little bit there so you can see. So that's your iliac artery, and then the femoral artery running either side here and here, and you can see this one just stops there, and then there's no blood getting down there. Okay, so this guy had a 65 to 74% occlusion just above the profunda femoris, which is you've got a superficial femoral artery and a deep femoral artery, and this one's the deep femoral artery. Okay, so he had pretty much a 3/4 blockage of that artery, so his leg wasn't getting any blood. He started his things that you can check for this. If I just go back a bit, bear with me a sec. Things that you can check are, sorry, just go back a few. In clinic, you can have a look at these things. So you can do a pulse assessment. You can check the pulses. You can check the pulses of the posterior tibial artery just behind the medial malleolus, so the inside ankle bone. And you can check the dorsalis pedis, which is one of the arteries on the surface of the foot. It's quite superficial, so it's quite easy to palpate that one. You can also have a look for capillary refill. So you squeeze the end of their big toe and then let it go, and it should go white and then immediately red again if there's good perfusion. So a good blood supply. You can do it on your fingertips as well. If you've done first aid course, you'll have been taught that. So you can do it on the toes as well. So that if you suspect that someone has got some kind of occlusion to their artery, then you can check the pulses. So I'm just going to go over that a sec. So what you can look for is something called radiofemoral delay. So the radial pulse is on the thumb side of the wrist, and then the femoral pulse is by that femoral triangle area. And you palpate both at the same time, and you feel for the beat. Okay, so you should feel them beat at pretty much the same time. Yeah, so if there's a delay, so you're feeling the radial pulse, and then there's a gap, and then a weak femoral, there is a problem somewhere between the radial artery in that arm and somewhere along that network of blood supply. Okay, you wouldn't know where, you wouldn't be able to tell where, but you would just know that there is something wrong. Okay, so you can do a radial femoral check. And if it was in the upper body, you do a radial. So you just check both pulses on both arms. So that's something useful to know. If that feels okay, let me just check. I'll just show you on here a sec, Natalie. Femoral. Okay. Trying to get one that's good for family viewing. Hold on, because it's in a bit of an intimate area, this one. Okay, so we can go this one. You're bound to get some dodgy ones. Okay, cool. So your femoral artery is just here, yeah? So you've got ASIS around there, pubic bone around here, and it's about halfway in between, just underneath the inguinal ligament. Okay? You can palpate your own. You can't do it through clothing, so you need to do it at a time when you can be in a state of undress. But you can palpate your own femoral artery, feel your pubic bone, feel your ASIS, go halfway, and it's around about there. Okay, and you have a bit of a dig around. But the way to measure pulses is not with your fingers, like poking like that. You need to use quite a broad contact. Because if you imagine the artery is, well, it's about the size of your thumb, really, that one is pretty thick. So if your fingers are just slightly off of it, you won't be able to feel it. But if your fingers are like that, then you're more likely to pick it up somewhere along the undersurface of your fingers. Okay, so just a little tip. And for one in your wrist as well. If you do that, it's really difficult to feel it. But if you do that and put it across that way, then it's easier to detect. Okay, because you've got more feeling area, okay, of your fingers on their skin. So just a couple of tips there. Let's go back to that. Cool. So femoral pulse, ASIS to pubic bone, halfway along the line of the inguinal ligament, and then you feel just underneath that ligament, and you should be able to feel a pulse in there and palpate the radial one as well. No problem. Cool. And then if all of that was okay and the blood supply was good and their leg didn't feel cold and all of that kind of stuff, it could be femoral nerve tension, which is it's not a problem with the nerve root. It's just where the nerve is maybe restricted on its pathway down towards the front of the thigh. So the femoral nerve supplies your quads. Okay, it's all the front of the thigh. So this is the way to test it. This is a really old video that I found. It's about 10 years old. Okay, so this is where your femoral nerve is. So coming from L234. Okay, so that's where it's coming from. Passes underneath the inguinal ligament. And then in this section here, this is where it supplies. So it supplies the front of the thigh and all of your quad muscles, basically. Okay, so this is the test for it. So what you do, you get the person lying on their side, curl up into a ball, tuck their chin into the chest, and then you get them to hold onto their bottom leg to make sure the pelvis doesn't move. And then you hold the top leg and stabilize the pelvis. And then you bring their leg back. And as soon as they feel some kind of stretch on the front of their thigh, then you stop the test and you get them to lift their head back. And if the symptoms ease from the thigh, it means that it's more likely to be neural. If the symptoms don't change, then it's more likely to be tight quads. Okay. Or you just haven't got enough range to be able to test the femoral nerve properly. So just go through that again if you've never seen that before. So what we're trying to do is stretch the femoral nerve. So we know where it goes from. Just play that again for you. So we know where it goes from and where it travels. And in this position that they're in, it will stretch the nerve. So L234 are the nerve roots. So if you imagine the position that he was in just then with the leg back, that's going to open up the front of that hip, which is going to put tension through that nerve. Okay, cool. I'll tell you in a sec, Peter. Yeah. The head movement is really important. So that's a really good question. Okay, right then. So get them into position, curled up into a ball on their side and head tucked in. Now, I'll just pause that there. The reason why you've got your head tucked down is because you're trying to create tension through the whole of the nervous system. So by bringing the head down, you're stretching the spinal cord from the top. And then by bringing the leg up, the bottom leg up, you're stabilizing the pelvis. And the way to stretch or put tension through the femoral nerve is by extending the hip. Okay, so we've got tension through the top with the head, and then tension through the bottom with the hip position. Okay, if I just play that here, so tension through the top here. And then the nerve comes down here, around there. And now that position there, everything's moved now. That stretch there, I'm going to just hold that there. That stretch along that thigh there, coinciding with that stretch there, is going to maximally elongate the pathway of the femoral nerve. Okay, it will also stretch your quads at the same time because of the position you're in. So what you've got to try and do is keep that leg there dead still so that doesn't move. But when they feel a stretch, you then get them to take their head backwards. So you're not changing the position of the leg, but you're changing the position of the head. So if the tension eases off, it can't be your quads that's causing the symptoms because you haven't moved the quads. Yeah, you've only changed the head position. So it's more likely to be the nerve than it is the muscles. Okay. And there's loads of different tension tests that you can do. Yes, it does. Yeah. Yeah. All nerves do, Peter. Yeah. So you can tension your nervous system by bringing the head down, bringing the legs up. And if you do both at the same time, you'll maximally tension the sciatic nerve. So there's different positions that you can get into depending on where the symptoms are. Let me just, it's difficult to show the leg ones because I need someone to demonstrate on. But let me just show you this. I'll just move to a bigger screen if I can. Just get rid of that. And the video. Okay, cool. Right. Okay, let's try this. if you can see. Right, so if I get in that position, if you try this one, so if you you can get yourself up, pop your hand like that, keep your elbow dead straight, and then turn your wrist around. That's going to put tension through the median nerve in your arm. Okay, so brachial plexus underneath your collarbone, and then down the inside of your arm, down the in between your ulnar and radius, and then out through these 3 fingers and a little bit at one. Okay, so you like that. If you feel tension in that position anywhere in your forearm or your bicep, you then shrug your shoulder up to see if the tension eases off. Okay, if you felt tension in your forearm, and then when you lift the shoulder, the forearm tension changes, it's more likely to be nerve, because you haven't changed the position of the forearm muscles. Yeah, so it's more likely to be the nerve tissue that's causing the sensation of tightness. Okay, if you don't feel sensation there, then you do that. Keep your head dead still, and then you slowly start to take your arm out to the side. And then if you feel tension, just shrug the shoulder. And then if the tension eases, again, it's more likely to be nerve. Okay, so you can try that as a nice easy one. What if it's in the palm? Yeah, so if it's in the palm, shrug the shoulder. Does it go when you shrug the shoulder? Yeah, so if it goes when you shrug the shoulder, it can't be a problem with your palm, because you haven't moved the palm. You've just moved the shoulder. Yeah, it's more likely to be the nerves that follow that pathway. So all of this stuff is called neurodynamics. Just pop that in there. Yeah, that's how you spell it. Yeah, neurodynamics. So there's a couple of researchers in this area. A chap called Michael Shacklock, his name down, and David Butler as well. There are some really cool videos. Online for them. This is a really important one for tennis elbow, because I get quite a few people coming in with tennis elbow problems, and actually their symptoms are from the radial nerve rather than from the extensor muscles. So you do a radial nerve tension test and it reproduces their pain. Yeah, reproduces their symptoms. So it's another one of those orthopedic tests that you can use to rule in or rule out certain conditions. But that's a nice one, because that's the kind of thing that we're likely to come up against. So if someone's got tight quads, have they got tight quads, or is it the femoral nerve that's causing the tension? Yeah. So and that's one of the things that you can test. Cool. I think, yeah, that's it. Brilliant. Good questions again, guys. Really good. So a few things for you to have a look at. And we've got a session with Dan Lawrence again next Monday at 8. So we're going to have a look at ankle rehab on Monday. And I'll do another new OSCE as well for Monday at 6. Okay. So I'll see you next week. Cheers, guys. Have a good weekend.